I'm Katharine Rolland, and I am a Tissue Viability Nurse Specialist in NHS Lothian, which you may know better as Edinburgh in Bonnie, Scotland. I've been a tissue viability nurse now for just over 5 years, and I cover community and acute. And I'm very passionate about pressure ulcers, but really I just love all wounds. Thank you so much to FLaminol for having me on today to host and also to talk about my case study. So I'm sure either you've read or you're just about to read the Wounds UK article. And what I'm doing today is I'm just going to explore in a little bit more detail one of the case studies that you will read about in that paper. And here it is there. So the case study, our gentleman is 59 years old. He's got COPD, psoriasis. He's quite a heavy smoker. But despite this, before coming unwell, he was pretty well. He drove a school bus 5 days a week and had a good quality of life. He was brought into the acute hospital on the 5th of January with a pneumonia and renal failure. As well as that, he had this new erythematous rash, which you can see there. And a lot of the medical staff and nursing staff were concerned about how rapidly this rash appeared and was spreading. We didn't initially know what it was. 2 days later, as you can see, the rash returned blistering, and it was incredibly painful and sensitive for him, and he was diagnosed as having a cutaneous vasculitis. This then developed, and by the 11th of February, the blistering had stopped, but it had left behind this deep necrotic damage. The pneumonia was resolved, however, the renal failure persisted, and he was transferred to another hospital for ongoing renal input and dialysis. So I lost touch with him at this point from the acute. I then picked him back up in my community role on the 12th of March, and this is what we had. When we look at our Times wound bed assessment here, we had 60% slough, we had 10% necrotic tissue, and we had 30% granulation. There were no signs of infection, but obviously there was a high concern that this could become infected. You can see there our measurements were 21.5 by 6 centimeters. What was the treatment plan? So the aim here, because of the size of the wound and where it was, and the fact that it was really impacting his life, he was off work, he didn't feel he could go out of the house, and we really wanted speed. And what we wanted was to remove the devitalized tissue, remove that necrosis, and allow application of negative pressure wound therapy. In our case, it was the VAC therapy. And in order to apply that, you want 25% slough or less on your wound bed. So what we did was we applied FLaminol Hydro with an adhesive silicone foam on the top, and that was changed every 3 days. We chose FLaminol because it removes debris, it promotes moist wound healing environment, it protects against infection, and it's really conformable and easy to use. It worked really effectively, and within 10 days on the 22nd of March, although the size of the wound was pretty much the same, we had a lot less slough, and we were able to commence negative pressure wound therapy. That went for 8 weeks. And this is how it looked afterward. The Times wound bed assessment now, we have only 10% slough, 70% granulation, and 20% epithelialization. There was no signs of infection. There was still minimal exudate, but there was more exudate than there had been pre-starting VAC therapy. Our aims now are to promote moist wound healing and encourage the continued healing of this wound, which, although smaller, was still sizable, and it was still impacting his life. What we really wanted to do was we wanted to get to a stage where he had less trips, because he was going every 3 days to the treatment room. We wanted less trips to the treatment room. We wanted him to get back to his job. We wanted him to be involved in self-care. He felt like he had a really positive experience with FLaminol from the first time, with its rapid removal of the necrotic tissue. And when we suggested trying FLaminol Forte, the same name, the same tube, but a different color, he was really happy to get on board with that. And he was able to reach the wound himself and apply that We got him Dopplered, fitted up and measured for compression hosiery. And we got to a situation where he was able to change the dressing himself. And he was only going in to see the treatment room nurse once a week, so that she could kind of have oversight, double check he was doing fine, and redress that for him. So that continued. He was every 3 days. He had FLaminol Forte, adhesive silicone foam, and his compression hosiery. And this was him by the 31st of August, 5 centimeters by 2.5 centimeters. We were all really, really pleased with that. And if you have a look back, that's how far we came. He was back to working, and he's minimal dressings, minimum impact to his life. And he said himself he really didn't expect it to heal. So we were all, really, really pleased with the progress that we made with what were 2 pretty simple wound plans, really. So what was the outcome for him? Back to work, self-caring, in the treatment room once a week. His hosiery was reviewed every 6 months, but as we know, leg ulcers are very common at reoccurring, and this is a lifelong commitment to compression hosiery, to compression garments, and to making sure that the wound doesn't break down again in the future. The study by Guess 2020, which well-known study, showed that on average patients can receive up to 8 different dressing types in a 1-year period. This isn't necessary. FLaminol's really versatile, and in this situation we were able to change from the hydro preparation to the Forte preparation, but fundamentally FLaminol gel, silicone foam, and compression. And the patient felt happy with that. He felt like he trusted FLaminol and he believed in it from the first time he had it. And also he felt it was easy enough to apply, and he felt secure using it. We don't need to keep changing dressings when you've got big complex wounds. One dressing that's versatile will follow you right through your wound care journey for weeks and months. So the positive patient's experience that he had initially influenced dressing selection, but also the fact that we don't need to be overcomplicating our wound care plans. We don't need to be making sandwiches. We don't need to be changing things for the sake of changing things. If it's not broke, don't fix it. And that's definitely what we found in this case study. Thank you so much for listening, and thank you for joining us on this webinar.